Good afternoon, everybody, and welcome to today's webinar on the inclusion of child and adolescent TB activities in the Global Fund's Mission 2021 to 2023. I'm just going to... and just before we get started on today's webinar, I'd just like to go over a few items so you know how to participate in today's event. We ask that you put yourself on mute for the presentations, and for those of you who are unable to mute for the duration of the presentations today, we will mute all the lines so that we can clearly hear the presenters. You will have an opportunity to submit text questions to today's presenters by typing your questions into the chat box panel in the control panel. You may send in your questions at any time during today's webinar. We will collect these and address them during the Q&A session at the end of today's presentations, and there will also be an opportunity to we can open the lines to ask questions as well. So without further ado, it is my pleasure to introduce you today to today's chair, John Paul Dongo. John Paul Dongo is the country director of the Union Uganda office and is the lead on the Union and CDC's Sub-Saharan African Child and Adolescent TB Centre of Excellence. John Paul, over to you.
Thank you, Grania. Briefly, I'd want to take us through, just for us to get a glimpse on what the Sub-Saharan Africa Regional Child and Adolescent TB Centre of Excellence is. So this is a virtual platform that is led by the UN in collaboration with the CDC Global TB Branch. The Centre of Excellence has been established to provide regional support in capacity building and evidence base for programs to implement and strengthen the detection, management, and prevention of TB in children and adolescents. And this is really all aimed at enabling the member countries to achieve the post-2015 NTB strategy targets and the UN high-level meeting targets. It's really in its initial stages of establishment, and this is following a meeting that was held in Uganda, Kampala, in August 2019, with representatives from 9 sub-Saharan African countries, NTBs. And these were really Uganda, Kenya, Ethiopia, Malawi, Mozambique, Tanzania, Zimbabwe, Zambia, and Eswatini, all of which were invited for this webinar. The Sub-Saharan Africa Regional Child and Adolescent TB Centre of Excellence is coordinated by and through the Union Uganda Country Office, and we plan to work with and support member NTBs on mutually agreed priorities to improve child and adolescent TB prevention, care, treatment, and surveillance activities. As I mentioned, that we have 9 countries. We have already submitted invitation letters to the 9 Ministers of Health, NTBs, and this is really to formally invite them to join the Sub-Saharan Africa Regional Child and Adolescent TB Centre of Excellence. These are really the initial countries, but as the COE gains momentum, we think there will be room for expansion and probably be able to include other countries. As I mentioned, this is a virtual platform that will have a range of engagements, including webinars like this one we're having today. And a lot of the topics we should be discussing will depend on prioritized topics from member countries, but we also intend to have a lot of speakers within the member countries participating in the webinar presentations. We'll also have child and adolescent TB training, but also as the webinar, as the COE grows, we plan to have annual COE regional meetings, and these are planned to be rotated among member countries to ensure that the work of these countries is presented, but also to promote South-to-South learning. within the member countries. We'll also work with the member countries to do a lot of publications, presentations, symposia, workshops, and these we plan to have them presented within the annual Union World Lung Conference. The Union, in collaboration with CDC, has also constituted an advisory committee of highly respected organizations and individuals who will provide guidance and oversight of the COE platform. So I also know that most of these member countries, these advisory committee partners are part of today's webinar. So that's really a brief about the COE. I really want to make sure that we all have an idea what this platform is all about. So to dive into today's webinar, this will be a 1-hour webinar, and each speaker has 15 minutes of our presentation. And at the end of the 3 presentations, we'll have 15 minutes of Q&A from the members that are part of the webinar. The objectives of this webinar are mainly 4, and these are: 1, to discuss the importance and the mechanism to ensure the inclusion of child and adolescent TB activities into any upcoming Global Fund applications. 2, give an update on the new Global Fund mechanisms, including the applications for matched funding and making a full expression of demand through unfunded quality demand register, grant negotiation and reprogramming, as well as portfolio optimization and how this can be used to scale up child and adolescent TB activities. We'll also look at we'll also share tools such as budgeting tools to facilitate the inclusion and appropriate funding for child and adolescent TB activities. And finally, we'll also be able to share national experiences of implementing a child and adolescent TB activity with support from the Global Fund mechanism. So today we have 3 presenters, and I am pleased therefore to invite our first speaker, Dr. Anna Skandigli. Dr. Anna is a medical doctor. She's a specialist in infectious diseases. She's the tuberculosis advisor and focal point for childhood TB at the Global Fund. She has previously worked for several years in Africa, mostly as a TB HIV advisor for ICAP, Columbia University in Mozambique, and in many different settings in Africa, Latin America, and Asia, as well as a TB consultant for the Union. Today, Dr. Anna is going to share with us the new Global Fund cycle and the opportunities for childhood TB. Dr. Anna, over to you.
Thank you, John. Thanks a lot, to everyone, to the organizer for this initiative that I think is really relevant and important. And thanks for the opportunity to share with you these 15 minutes of presentation on the new Global Fund cycle and opportunities for pediatric TB. Just to make clear that I don't plan to go much in procedures on how to apply to the Global Fund, because I think you all know, or if you don't, you can find a lot of information on the Global Fund website or with other colleagues of the Global Fund that are working more on access to funding. The aim of my presentation is to focus mostly really on the key priorities for TB in the next cycle with the lens of pediatric, of course, childhood TB, and the opportunities that there are also beyond the allocation, beyond the TB grants. So I ask kindly to move to the outline. So this is the content of the presentation. Quickly, a few words on the replenishment and the new cycle, the key priorities for this new cycle, the additional funding for TB activities and TB initiatives beyond allocations, and a quick update on the new TB Modular Framework and the other key elements in the application material related to childhood TB. And finally, just some conclusions. So the next one, please. The next slide, and again, the next one on the replenishment. Very quickly, just to remind that we had a very successful replenishment last year. That was the most successful since ever in the story of the Global Fund. So now there are more funds, and you can see in this slide the approximate allocation by region for TB. This is represents an increase of 20% overall compared to the previous cycle. And just to note that the 20 top TB burden countries account for 70% of the entire allocation for TB. Next one, please. Moving straight to the key priorities for the Global Fund with this new cycle and new funding and more funding than before. Here is just a way to try to summarize all together the big priorities. We can say that the big priority is finding the missing people with TB overall, and so any intervention that improve case finding, and this means case finding for TB, susceptible TB, drug-resistant TB, but also people who have a latent TB infection and may need preventive therapy. So all interventions or strategies to find missing people with TB are welcome. This means intensified, active, systemic case finding, innovative approaches that may include private-public mix where relevant, maybe more in Asia, but also in many countries in Africa, this still makes sense, and community engagement. Also including new screening and diagnostic tools, also including artificial intelligence, connectivity solutions, just to increase and improve case finding. This, of course, needs to be linked to treatment. So, of course, we incentivize patient-centered and decentralized patient support for TB-susceptible and drug-resistant TB, including the uptake of the most recent guidelines, especially the all-oral regimens for drug-resistant TB. And prevention is part of this package because every time we make effort to find missing people with TB, every time we do screening for TB, we can also identify patients eligible for TB preventive therapy. And therefore, these three components should be really linked as part of a comprehensive package of TB interventions. So the next one, thanks, is listing a bit more clearly these key priorities for the next cycle. So again, missing people with TB, missing million actually of people with susceptible TB and drug-resistant TB, and therefore the first priority is finding them and treating them. And this includes clearly children and all interventions that are specific to this population. If we can remain on the previous one, yes, thanks. This includes also strengthening lab systems using the most available sensitive screening tool and diagnostic test. This includes also acceleration of, as I said before, all oral regimen for drug-resistant TB, engagement of private providers community, addressing comorbidities like TB, HIV, where this is most relevant, and diabetes mellitus, for instance, addressing high-risk and vulnerable population, including children, and again, scale up of TB preventive therapy, especially for people with HIV and children. So the next one, thanks, is just another way to present the same. So it's really trying to elaborate in the strategy and focus. So putting pieces together, the PPM, the community program quality improvement and efficiency, that means really to improve the quality of the entire TB cascade, and also service integration, integrating with HIV, with integrated approaches also in terms of service delivery, health, primary level of care, nutritional services, immunization campaigns. This is very relevant, especially for childhood TB interventions. The use of data to inform programs and to take decisions and make corrections. So this is just a way to show the same that I was saying before. The next one maybe is more specific on TPT. It's just a way to show the various different opportunities that exist under the Global Fund to support TB preventive therapy scale up. So first of all, of course, through the grants, so through the funding request using the TB and also the HIV grants. And in this sense, technical partners are supporting and will support countries to find the right way to propose TPT interventions. Also, there are, and I will show you later, some special initiatives that are giving some additional funds specifically for TPT and for people with HIV to selected group of countries. Then there are funds also to provide technical assistance to support countries in planning and in implementing TPT interventions. There may be opportunities through something that is called portfolio optimization, that I don't know if you know what is that. This is an additional pot of money that it becomes available in more occasions during the cycle. And that is for countries that have included in the PAR, the Prioritized Above Allocation request, some important interventions that have not been covered by the grant. All these PAR, all these Priority Above Allocation requests are included in a register that is called Unfunded Quality Demand Register. And this register is used, for instance, when there are additional funds, like for the portfolio optimization, to be given in a competitive manner to countries that have included interesting, impactful, and strategic interventions. So far, some countries have received already this additional money during this cycle for TPD intervention. And finally, well, we try also to contribute to the market shaping, especially for the cost of drugs, that, for instance, in the case of rifampicin has been relevant, and to increase advocacy with the TB and those HIV communities to increase the domestic and donor funding for TPT. So we can maybe go to the next one, that is just the outlining form, and that we move to the strategic initiatives. Just 3 slides to show you additional opportunities beyond the grant. So these are in addition to the allocation for TB, and are for selected group of countries. So this is called the TB matching funding to find missing people with TB, also called catalytic funding. In the current cycle has been for 13 countries. In the new cycle is for 20 countries. So the same 13 that you can see on the slide, plus other 7, for a total number of 20 countries. And these 20 countries represent the 82% of the total missing people globally. This is a pot of money that is given in addition to the allocation on TB. It needs to match with the intervention that are included in the proposal, and is really aimed to find missing people with TB, but again, not only TB, but also drug-resistant TB, and also people who need preventive therapy. And any innovative tools and approach are very welcome, should be really innovative. The next one is again a strategic initiative. The next slide, specific on TPT for people with HIV. And this is for 5 countries listed there in terms of additional money, matching funding, plus technical assistance, and other 4 countries only for technical assistance. This is specifically for people with HIV and for scale up of TB preventive treatment. And the next one, please, is for the West and Central Africa region. Still is an additional pot of money for 5 countries, those written there. And this is a bit broader because it's again to improve finding of missing people with TB, but also to improve treatment outcomes and to push a really innovative approach for community TB responses, to push approaches to address vulnerable groups and especially children and people with HIV, including also technical assistance, also local technical assistance, and trying to improve and strengthen as much as possible high-level engagement with the relevant stakeholders and implementers as a region, not only at country level, but as a region, as the West and Central Africa region. So these are 3 special, we can say, initiatives that bring additional money, and all can be utilized also for children, to find missing children with TB and drug-resistant TB, and to put children in preventive therapy. The next one, please, is again the outline, just to show that we move a bit more now on something specific on the application process, or what is new in terms of pediatric TB. This is just the material that you all know, and that is available online. So the frequent asked question, the modular framework, the applicant handbook, the funding cycle brochure, and a set of information notes and technical briefs, one specific for TB, but then there are for HIV, there are for gender and human rights. There is one for TB HIV specifically that is the result of an assessment that was done, and best practices on TB HIV joint application. So all this material is available online, including also guidance on catalytic funding, the matching funding for the 3 special initiatives is available online. The next one, please. The next one is just showing the technical information note. Yes, this one. available in English, French, and Spanish, just to show that children are addressed in multiple parts of this TB information note, in terms of key population, but also in terms of integrated activities, in terms of maternal-child reproductive health, in terms of case finding, treatment, prevention, and also with several links to technical guidelines and documents and to the pediatric roadmap. So we tried to include as much as possible children in these information notes that are those used mostly by consultants and countries in preparing the funding request. The next one, please, is to show what is new in terms of the modular framework that is that tool that accompanies the funding request, and it is used for the proposal, but then also for the grant making and the implementation. Here, I would like just to emphasize the three last bullet points, because are those more relevant to pediatric TB. So the one about the new intervention under the three core modules that is specifically addressing children. So before there was not this intervention, now there is the intervention children. Is within the key population, so children, minors, and mining communities and mobile populations, and is within each of the three main modules. So within TB care and prevention, within TB HIV, and within MDR-TB, children are repeated as a key population. Then we revised also some indicators related to TB preventive therapy, and for instance, now we have also indicators on TPT disaggregated by age, so children under 5, 14, and older than 15. And then overall, an additional disaggregation by age, gender, and HIV status of most indicators. The next one, please, is showing, for instance, what is included in the childhood TB intervention. So key population, children, new intervention under the three modules. For instance, this includes active case finding, and this implies also sample collections, sample testing, screening, use of chest radiography, everything related to contact investigation, including community approaches, the provision of child-friendly TB medication, the provision of TB preventive therapy, including the new regimens. Now we have also one more. And everything related to training and capacity building focused on responses for children. So this is just an example of what is mentioned in the key population children new intervention under the three TB modules. Finally, the next, please, I go just to some conclusions. So again, finding missing people with TB is the priority. But just to emphasize that this finding missing people with TB implies really case finding for TB treatment and for TB prevention. So through that, we find people with TB, with MDR-TB, with latent TB infection, and we provide the right treatment or preventive treatment, and we do provide also prevention. And this is an opportunity to increase TB detection among children and adolescents and to offer TPT to those in need. It's very important to have a strong coordination country level to enable the integration and leveraging funding opportunities for childhood TB. So of course, early should start discussion at the national level, including the various health sectors, including different disease programs and disease strategies. There should be advocacy to integrate maternal and child health in the disease-specific policies. The CCM should participate in the country dialogue in the preparation of the funding request. And the funding request should include prioritized evidence-based intervention for children and also for mother and for child health services. The resilient, sustainable system for health, so the health system strengthening is part of it. So integrated approaches, including community service delivery, or as I said before, engage in other services like nutritional services, immunization services. This depending on the specific country context. These should be opportunities to be explored within the TB and also within the RSSH modules and interventions. The Global Fund is willing and is already working with partners and with countries to support the rapid uptake of the new guidelines, because recently we have been noting a lot of positive changes in guidelines for MDR-TB and for latent TB infection and for TB diagnosis. And there may be opportunity within the grant and beyond the grant, as I showed before, through the strategic initiatives, finding missing people or catalytic funding, matching funding, through portfolio optimization, and through other initiatives. So it's also very important at the time of the funding request to include the priority above allocation request at the same time of the funding request, because otherwise later update of the PAR is not really easy. It's discouraged and is accepted only if it's really very strongly justified. So it's really important to include it at the time of the funding request. The same for the matching funding. The request should come at the same time, so together with the funding request. And also for the matching funding should be really strategic, innovative, should be avoided and not prioritize a long list of intervention. Rather should be really more focused on a few impactful interventions, ideally based on evidence, country evidence, to be much more successful. So I think that I kept the 15 minutes, and so I remain available for questions at the end of the session. Thanks a lot.
Thank you, Anna, for that very wonderful presentation. Please note that we can continue to send in questions through the control panel, but also at the end of the third presentation, like I earlier mentioned, we'll be able to open up the button so you're able to ask the speakers directly. So it's now my opportunity and pleasure to invite our second speaker, that is Dr. Martina Kasengi. Dr. Martina holds a PhD, and she's currently collaborating with EGBAF as acting Technical Director for the United Funded Pediatric TB Project, CAP-TB. And this project supports pediatric TB specific interventions in 9 African countries in India. Prior to joining EGBAF, Dr. Martina has worked as a TB advisor at MSF Access Campaign for more than 10 years. She currently serves as a core group member of the Child and Adolescent TB Working Group. Dr. Martina is going to share with us budgeting tools for pediatric and adolescent TB interventions. You're welcome, Dr. Martina. Over to you. Dr. Martina, you're in mute. Hello, Dr. Martina. You're still muted. Okay, there you go. Yeah, we can hear you.
Can you hear me well?
Yes, please go ahead.
Okay. Thank you very much for the nice introduction. I would like to start with the next slide. I would like to start
Dr. Martina, we seem to struggle we can't get you so clearly.
Hello, can you hear me? I can hear you very well.
Please go ahead. Please go ahead.
Okay. So if you can move to the next slide. Yeah, please let me start thanking all the people that have been involved in this effort of tools for pediatric who has been really instrumental in the development of the budgeting. And then I need really to emphasize that this has been a large and very nice collaborative effort. And I would really like to thank all the people that you see listed here who have really spent a lot of time and given very useful input and contribution on the development of this tool. So next slide. Let me give you a quick outline of the presentation. So I will start with giving you a quick intro and rationale why we decided to develop these budgeting tools. And then I will quickly go through this overview of the Global Fund TB Modular Framework because Anna has already given a very nice introduction and overview about this. And then I will move into the budgeting tools that partners have developed. And then quickly mention the WHO One Health TB Companion Handbook, just to give you a bit of background so that you know what it is and what we have done to integrate the pediatric TB budgeting tools into this WHO tool, and then walk you through the budgeting tool packages, budgeting toolkits that we have developed and made available. So next slide. So why did we decide to start working on the childhood TB budgeting tools? This is because we realized that, and we, many people raised consistently challenges in having dedicated funding to get the childhood TB program happen and running. And partially, one of the reasons for this is also that in general, on average, there is weak know-how and experience on how to roll out and scale up pediatric TB specific intervention. And therefore, not enough knowledge and expertise, again, in average, globally speaking, in how to plan and accurately budget for pediatric TB specific interventions. So this is what we decided basically as a captive pediatric TB. We led the establishment of a formal platform that with the aim of really enable information sharing and coordination among key players on pediatric TB. And this informal platform is called the POSE group, and you can see listed here the key members. And as a POSE group, we really discussed, what could do regarding this key gap in getting appropriate funding and resources for pediatric TB interventions, and therefore we decided to really focus on the development of these pediatric TB budgeting tool. So if you go next slide, I will move through the next two slides very quickly because, as I mentioned, this is something that Anna has already discussed. These slides have been kindly shared with me by Sabine at WHO. And as Anna has already emphasized, there are some key example of interventions for pediatric TB that has been highlighted in the Global Fund TB Modular Framework. And without me going in detail about this, what I wanted to highlight here is that we really focus the budgeting tools on these interventions. Sure, also a good alignment with some of the specific interventions highlighted in the Global Fund TB Modular Framework and the development of the budgeting. So you can quickly go through also the other slide and move to slide number 7. You can go to, okay, thank you very much. So which interventions? No, please go to the next one. So in terms of the interventions, one back, sorry. Okay, perfect. Stay here. So in terms of the budgeting tools and which interventions to pick, to focus on, what we did, apart from, as I mentioned, trying to align as much as possible with the Global Fund TB Modular Framework, was also to really focus on interventions that have a critical role for the rollout of childhood TB programming, and also interventions that include a specific and different needs for pediatric population, because we assume in any case the general TB interventions are in general budgeted for. So we really wanted to build the tools to allow for the budgeting of the specific needs of the pediatric population. So based on that, the priority interventions on for the development of the budgeting tools were the household contact investigation, TB preventive treatment, And given, the emphasis on scale up of TB preventive therapy and treatment, and also the availability of new regimens, we decided to actually build a more comprehensive tool that would focus not only on children, but also on HIV positive adults. Then the sample collection procedures for children, because as we've seen, the laboratory confirmation is weak, also because there is very little experience and support and resources for implementation of sample collection procedures. And then nationwide programmatic training on pediatric TB, because build the capacity to manage pediatric TB. So, and this training tool, this budgeting tools includes budgeting for site support and supervision. So please go next. So in the next slide, basically, this is the process. To give you a quick overview of the process we went through. So we have identified these 40 interventions, and we developed the budgeting tools through a collaborative effort by the various partners that compose the POSE group. The list of activities was really identified through consultation with the various partners and with a focus on child TB budget line items. For the budgeting tool on the training program for pediatric TB, we really received, and I want to thank here the Uganda National TB and Leprosy Program that was really able to provide a great input on this tool based on the experience of Detect TB and further scale up they did at national level. It was a 3-month consultative process. And the pre-final tools were shared with the key stakeholders such as the core group of the Child and Adolescent Working Group, and were reviewed, and input was included. And then finally, an important piece of work that we did once we had this kind of standalone for budgeting tools, we really worked closely with the WHO team, Ines Garcia in particular, to integrate these budgeting elements into the WHO One Health TB module companion book. And Ines and Angela did a lot of work on this. So if you go next, let me give a quick introduction for those of you who are not familiar with the WHO One Health TB module companion handbook. This is a tool that WHO is supporting and is kind of proposing to countries for the development of comprehensive and integrated budgets for TB programming. It's part of a larger software, which is called the One Health software, and that allows actually comprehensive budgeting across the different, disease area. So it's a very good tool because it provides this opportunity for comprehensive and integrated budgets. On the other side, the limitations that we found is that the activities specific to the child TB interventions were not presented in this tool. I guess there is somebody typing. If we can kindly mute, I can hear somebody typing in the background. So the activities specific to child TB interventions were not included in the WHO One Health tool, and this has now been addressed through also the collaboration between WHO and the POSE group. And it also is quite complex, so requires a trained personnel to be able to use it appropriately. If you go next, so I'm now kind of presenting to you the budgeting toolkits that we developed and are available for use. So let me start with the toolkit number 1, which is based on the WHO One Health TB module companion book. This is, you can see this is available through this link on the WHO website. So in collaboration with the work done by the POSE group, this has been updated and allows now budgeting for the TPT interventions for both adults and pediatric population, and is including all the shorter regimens recommended by WHO, including 1 HP, allows budgeting for sample collection procedures for children, and in particularly looks at induced sputum, nasopharyngeal aspirate, gastric aspirates, fine needle aspiration, and stool. Allows for budgeting of household contact investigation. This was actually already included, but we slightly revise it. And then includes budgeting for pediatric TB training, although it was only possible to include the, let's say, the final total cost for pediatric TB training. So that's at the moment, the 1L2 doesn't support a budget calculation for pediatric TB training. And this is why, as part of the toolkit, we have also included, as you can see, the pediatric TB training budgeting. So we have developed this budgeting tool largely based on the Uganda experience. Again, thanks a lot to the Uganda NTLP to share their experience with us. And it supports really, the tool is based, is built in a way that supports the budget calculation for developing a nationwide pediatric TB training program. So what needs to happen is that once the total costs are calculated through this budgeting tool, they need then to be included into the WHO 1L TB companion handbook. And then a last component of this toolkit number 1 is a fact sheet that Angela Cairo, our consultant, has developed, which really provides stepwise guidance on how to budget for the child and adolescent TB intervention using the 1L TB companion book. If you go next.
Hello, Martina. 5 more minutes for your presentation.
Next slide, please. Yeah, thank you. So this is just to show you where you can find the 1L tool in the WHO webpage. Here you can find it. Basically the WHO page. So so maybe if you move, can you move back one slide, please? No, back. Back one more. Okay, so basically this is how you can access this toolkit number 1 that is based on the WHO 1L TB module companion book. And if you are interested in using, if you have already adopted or you are interested in adopting this WHO 1L TB module companion book, this is the support that you can access to. So for from the ECPAF side, Angela, the consultant, will collaborate with ECPAF to provide support in CAP-TB project countries. And then, as you can see, CDC is also available. You can contact Brittany Moore. You have the contact here for more information to get support on, how to use and adopt the WHO 1L companion. So if you are, this is mainly targeting countries that are already using different tools for budgeting. They didn't adopt the WHO TB module companion book, and they are not, let's say, interested in adopting it. You can consider using the POSE budgeting tools in order to integrate into whatever budgeting tool is in use the following key intervention: the TPT programming, so including the use of shorter regimens, and the priority pediatric TB specific interventions that we discussed before. Kind of key limitations that you need to be aware is that these are kind of vertical tools, so they only allow for budgeting of a subset of specific interventions, and the budget figures will then have to be consolidated into larger budgets that take in consideration the complete cascade of care. And you have the link that allows you to access the budgeting tools, the POSE budgeting tools that compose this toolkit number 2. Slide. This is just a summary of the key resources and contact people for the budgeting toolkit number 1. At WHO, you have Ines for CAP-TB project countries, Angela and myself, and for PEPFAR supported countries, Brittany, and you have all the contacts details there. And for the budgeting toolkit number 2, which is based on this single Excel-based budgeting tools, again, the key contact people are Brittany and myself. Last slide. Before the acknowledgements. So if you are interested, of course, this webinar was not supposed to really go in details into the budgeting tools and provide a deep dive, but if any in the audience is interested in getting learning more about the tools and getting a more in-depth overview, please email to the people listed here, Brittany, myself, and Linda. You have the contact details. Because we can discuss about having a separate webinar that will allow to describe in detail. Thank all the people, if you go to the next slide, all the people and institutions who have been devoting a lot of time and energy in the past 3-4 months to develop these tools, and thank you for the very nice collaborative days. Thank you very much.
Thank you, Dr. Martina, for that elaborate presentation. I want to apologize that we might go a little bit short past the 1 hour mark, but we'll try and do the next presentation as fast as possible, and then we'll allow our speakers to answer the questions in the control panel. But also, if there are any other questions that will probably come up, we're happy to respond to them off the webinar, given the time constraints. So our final speaker is Dr. Triahami Savia. Dr. Savia is the Assistant Commissioner in charge of the National Tuberculosis and Leprosy Division at the Uganda Ministry of Health. She has a Master's of Public Health from Lund University, Sweden, and a bachelor's degree in medicine and surgery from Murray University of Science and Technology. She has 17 years experience working with government and non-governmental organizations, including the Ministry of Health, Makerere Joint AIDS Program, the AIDS Support Organization, in different capacities. In these different organizations, she has worked as a medical officer, medical coordinator, TB HIV advisor, regional AP supervisor, regional TB focal person, national coordinator for drug-resistant tuberculosis, and senior community TB technical advisor for TB on the USAID Defeat TB project. Today, Dr. Savia will share with us experiences of the National TB program in implementing a child and adolescent TB activity with support of the Global Fund in Uganda. Dr. Savia, you're welcome. Over to you. Dr. Savia, you're still in mute.
Can I be?
Oh, yeah.
Yes.
Yeah.
Yes. Thank you, Paul.
Clear.
Yes, you have done the introduction. Uganda has had a chance of using the Global Fund to find the children with TB. So I would like to share our experience. Next slide, please. So just take you through the context and then how we happened to do this in the current funding, what we have achieved, the challenges and lessons learned, opportunities, and any recommendations that we may propose. Next. So Uganda is one of the 30 high-burden TB HIV countries globally, and nearly half of our population is in the age less than 15 years. Our estimated incidence is 200 per 100,000 population, and in the just last year, 64% of the children estimated to have TB, which was about 12,000 people, were diagnosed and initiated on treatment, which was less than 50 by the time we did the current application. The uptake of preventive therapy, though still suboptimal, but we have improved since the time we made the application in 2017, from 8.4 to now about 27% in 2019. Next slide. So we have children in the strategic plan prioritized as a high-risk group category, and we included pediatric TB activities in our NSP application, the grant application that we did in 2017. We conducted a number of activities, including consulting with key stakeholders that are involved in managing children and taking care of children. And we submitted our grant with a component specifically on childhood TB. We specifically used the lessons learned from the Detect Child TB model that was implemented by the Union here in Uganda, which had demonstrated feasibility in decentralizing childhood TB care, with increase in the child TB cases and uptake for isoniazid preventive therapy for the under 5 contacts in 2 implementing districts in the country. So the model was adapted for scale-up by the program, and that is how we included some of the activities to cater for pediatric child TB. Next slide, please. So we got funding, and this funding for 2018 to 2020 included the childhood TB component. We prioritized 10 key districts that were not covering children, and implementation has been in those 10 districts. So what did we do there? We were able to orient district-based teams as mentors in the pediatric TB model using the Detect TB approach. We reached 61 mentors in 10 districts, and then that was added last year. We were able to develop action plans for bridging the gaps in the missing TB cases, and they posted these plans with the teams. We conducted district-led mentorship and supervision, and this is still continuing. We have one activity that we are yet to conduct, but we have been able to reach a number of health facilities, and we have used the data during these mentorships to guide on future actions at facility level to make sure that they cover the gaps that we find. Next slide, please. So in terms of cases, we have seen a great improvement since last quarter of 2018 through to the third quarter of 2019. That was July, September. We generally have reduced notifications when it comes to the October-December period, generally in TB, and the pediatric TB cases were also affected, but they still remained higher than the baseline in 2018. Next slide. So we find that when it comes to the subnational level activities, there are a number of things that the district officials are engaged in, and sometimes the pediatric TB activity may suffer if there is no continuous oversight to demand for such interventions to continue and use the data at that level. We also learned that we needed to engage the experts. The Detect Child TB model empowers low-level health workers at low health facilities to diagnose pediatric TB. And sometimes the experts, if not properly engaged to understand the approach, they may think we are doing the wrong thing. They think managing TB should remain in the hands of the expertise, the pediatricians. Skills building and confidence building takes time among the lower level health workers, and we need to continue the mentorship to sustain the gains. Otherwise, the people don't continue to take pediatric TB as a priority. Next slide. So we have a number of opportunities that we still promote our pediatric TB intervention in. Despite the 10 facilities that we are working in, the PTB component has been integrated in all our other program quality efficiency programs. We are conducting active case finding, where we have PTB as one of the key activities, especially contact tracing, and when the children are identified, those with TB are initiated on treatment, and those who need TPT are given isoniazid preventive therapy. We have had very great engagement in our NSP development process using the people-centered framework, and we have consulted widely, including consulting with health workers and specialists known to be experts for pediatric TB, and we've got their input in the strategies that we want to use going forward. We continue to prioritize contact tracing as a key intervention for finding children, and then we have the use of new tools. The children were initially prioritized, but for GeneXpert, but we continue this even in the expansion that we have had. The other opportunities we have had is the integration in the RNMCH and HIV programming, which may not be on this slide. And we'll continue to explore those ones. And school programming. Next slide. We also have taken advantage of TB-friendly formulations. We introduced this in this funding cycle, and the children are receiving the formulations. The chest X-ray, we have our IPs who are giving us vouchers, especially to reach to those children whom we can't diagnose using the lab. But also we have put some digital X-rays in this grant, and we hope to put in also the current grant we are writing, so that we can continue to strengthen the detection of TB in children, especially this X-ray that has a card for TB, that we can get direct interpretation even where we don't have enough interpreters. Interventions under the HIV, TB, and malaria have been also integrated there, like I said, and a number of stakeholder engagements have happened. Next. So we need to keep an eye at subnational level for us to sustain the gains in terms of making sure that the skills that health workers have got are not put to waste, and ensure they use their data during the routine service delivery. They try to see how many of the children are coming through. Integration of TB in key existing structures, including active case finding, contact tracing, and in the other areas like HIV, TB HIV, malaria, reproductive, maternal, RNMCH is key in making sure that we are able to reach to the children, and school programming is another key area that we need to use. So we want to thank you for considering Uganda to be part of this webinar and for giving us an opportunity to present. We thank all our partners. Thank you.
Thank you, Dr. Stavia, for that very good presentation. And thank you very much to all the presenters that have really given us very elaborate presentations today. So we want to answer a few questions that are in the control panel. I'll request Grania to peruse through and find any questions that are addressed to the different presenters. Then also, because of the interest of time, we are happy to continue this engagement of the webinar. So please feel free to contact us on mail. So if there are any other questions you want to have addressed to the different presenters, we'll be happy to make the connection. Over to you, Grania.
Thank you. So if everyone is willing to stay for another 5 to 10 minutes, then we will address some of the questions that have come in on the control panel. And I have a question here for Anna, and it's, are integrated approaches similarly being considered with linkage to pneumonia-related interventions, including ICCM and IMCI?
Thank you for the question. Yes, well, some countries, maybe not all of them, but some countries are using, for instance, the community platform for ICCM and to identify children at risk of HIV and TB, depending on how the package of services is defined. In most cases, they use the RSSH modules, so the health system strengthening modules, and especially the one on integrated service delivery or the one on human resources for health that includes also community healthcare workers. I've not seen very often in the TB modules, mostly on the RSSH modules, but definitely there are some countries, various, including this kind of integrated approaches.
Thank you, Anna. I now have a question for Dr. Stavia, and then I will open the lines for people to ask any questions after that. It's Dr. Stavia. What is the estimated proportion of missing persons with TB among adults and then among children and adolescents? And are you able to give an idea of what proportion of the Global Fund grant was allocated to TB in children and adolescents? Thank you, Dr. Stavia.
Thank you for your questions. The missing adults, as of the last global TB report, we were able to reach about 65% of estimated cases. So we are still missing a good number, and I see the children are also almost the same. We are reaching about 64% of the estimated children with TB. In terms of the classification under 5 and above, most of the children we are notifying are above 5 years. We still struggle to get the under 5s into care. So majority of the missed children may be in that age bracket as we continue to plan. Now, the proportion of the grant that is for pediatric TB, I may not have that offhand now, but we put some specific money for 10 districts that we are supporting.
Thank you, Dr. Stavia. I'm now open up the lines. Please unmute yourself if you would like to ask a question, as I have muted all the lines, so you will have to unmute. But now opening the lines if anyone would like to ask our presenters a question. Okay, if anyone is talking, you are still on mute. Okay, I have a question that has come in on the chat box. It's for the Centre of Excellence. So according to Anna's presentation, there's a visible need for advocacy at all levels. And is there plans for the Centre of Excellence to develop an ACSM framework? And I think, Roger, we may need to get back to you on that, but I will see if John Paul may be able to answer that. Over.
Grania, I think we'll be able to get back to the question after the call. Over.
But thank you for that suggestion. Any other questions from the line?
Hello, good afternoon.
Good afternoon. Go ahead.
This is Dr. Zimba from Zambia, Kevin. I would like to ask Dr. Stavia, is the NTLP in Uganda using TST part of for screening? Because I'm of the view TST can improve the number of cases that will be found in terms of TB disease and those who can be put on TB preventive therapy. Thank you.
Thank you. Can I answer, please?
Please go ahead.
Yes, we are not using TST. We are using a specific algorithm to help us in determining the children who may be having active TB and those who can benefit from preventive therapy, which has clear steps on how to classify the different groups and also what labs need to be done in case we have to take off a sample.
Thank you.
Hello?
Another question, please go ahead.
Hello. My question goes to Anna, and I was asking how did they determine the poor performing, which indicator they use to determine poor performing districts based on the variation of the childhood TB indicators? Thank you.
Sorry, but I'm not sure to have understood the question. So what indicators we use to evaluate what? Sorry?
And experience, they select poorly performing districts. So am I clear that which indicators will they use to say this is a poorly performing district?
So maybe it's for it's not for me.
For Uganda.
It's not for
It's for Uganda. Maureen, are you on?
Yes, yes, I'm on. Thank you.
Explain what
Yeah, thank you, Dr. Yeah, thank you, Dr. Stavia. So, as the Uganda National TB program, TB and Leprosy program, we do have key indicators that include the proportion of childhood TB among all TB cases, all forms. And then the other indicator is on the uptake of TB preventive therapy. So those are the two indicators that we use to determine the poorly performing districts. And then, of course, we looked at, we excluded districts where there was an active child TB project going on because we thought there's already opportunity and we need to improve access to the other areas where there's no targeted focus on child TB. So essentially we looked at, we ranked the districts based on the proportion of childhood TB cases as well as the uptake of TB preventive therapy. Thank you.
Thank you very much. I'm afraid in the interest of time, we've already asked people to stay on longer. If you do have any questions, as John Paul says, please either enter them in the text box while the webinar is still active, or you can contact us directly and we can put you in touch with the relevant people. So on behalf of the Union and the CDC Global TB Programme, I would like to thank all of our speakers today for a very thorough overview and I'd like to thank everyone for joining us today and for staying over. That is very appreciated. We have recorded this webinar and we will send round the link to the recording, which is both the audio and the slides, so that you are able to refer to it or share it on with others who you may feel would be interested to know the content of the webinar. So I'd like to thank our presenters and yourself for joining the webinar today, and I wish you a very nice end of evening. Thank you very much, everybody.
Thank you.
Thank you. Bye-bye.
Bye.
Thanks a lot.
Thank you. Bye-bye.
Thank you. Bye-bye.